طلاب المرحلة الخامسة من كلية الطب جامعة ميسان، السلام عليكم ورحمة الله وبركاته. نستمر وياكم ضمن محاضرات البرنامج الإلكتروني. Our lecture today about ocular trauma. Ocular trauma can be classified according to the site of trauma. Maybe trauma to the adnexia of the eyeball like eyelid or the orbit, or trauma to the eye globe or to the eyeball itself. Eyelid trauma may be periocular hematoma or black eye that consisting of focal collection of blood. It occurs after blunt injury to the eyelid and usually innocuous. But it is important to exclude trauma to the eye globe, to the orbital tissue or orbital fracture trauma, and basal skull fracture. Here is a picture of periocular hematoma, and this is subconjunctival hemorrhage. Other trauma to the eyelid is eyelid laceration, maybe superficial laceration or may be associated with one of the following. Lid margin injury. This picture shows lid margin injury, which may require direct suturing by 6-0 black silk, or canalicular injury that may require bridging by silicone tube which left in situ for 6 months. This picture shows canalicular injury and requiring this tube, which is silicone tube, to prevent the fibrosis and stenosis of the canal. Other trauma is orbital trauma or orbital fracture. As we know from our previous lecture in the anatomy, that the orbit is a bony structure consisting of 4 walls: the roof, the floor, medial, and the lateral wall. All these walls may suffer from fracture. A common fracture is blowout floor fracture or blowout medial wall fracture. The roof fracture and the lateral wall fracture are rare fractures. Blowout orbital floor fracture may result from fist trauma, leading to fracture of the thin bones of the orbital floor. Its signs are subconjunctival emphysema, subcutaneous emphysema, infraorbital anesthesia, periorbital ecchymosis, diplopia, enophthalmos, or ocular damage. CT scan can prove our diagnosis, and initial treatment is usually conservative management and advise the patient not to blow the nose. The 4 factors that may require surgery or may indicate surgery within 2 weeks are mechanical entrapment of muscle and herniation of the orbital content, fracture size more than half of the floor, enophthalmos more than 2 mm, or significant diplopia in the primary position. This picture shows orbital fracture or orbital floor fracture. This is more than the half of the floor fracture associated with the herniation of the orbital content, unlike this picture, unlike this. So this indicates surgery within 2 weeks. Here also, when the patient look upward, the right eye can move, the left eye cannot. So there is entrapment of the muscle here, and this may require surgery within 2 weeks. Blowout medial wall fracture usually associated with the floor fracture, so the same above management. Roof fracture usually by sharp object trauma and associated with head trauma, so rarely encountered by the ophthalmologist, usually by the neurosurgeon management. Lateral wall fracture usually associated with extensive facial damage and rarely encountered by the ophthalmologist also. This picture shows the right eye enophthalmos due to the blowout fracture and may require surgery within 2 weeks. Other type of trauma is orbital hemorrhage. Orbital hemorrhage means retrovulvar bleeding behind the globe. It is important due to associated risk of acute orbital compartment syndrome with compressive optic neuropathy, which can lead to blindness. Causes of orbital hemorrhage either traumatic or maybe iatrogenic due to retrobulbar usage of anesthesia for cataract surgery. Diagnosis of orbital hemorrhage may be proptosis, eyelid edema, ecchymosis, ocular motility dysfunction, elevated intraocular pressure, and decreased visual acuity. Treatment of orbital hemorrhage by lateral canthotomy and inferior cantholysis. This picture shows the lateral canthotomy with inferior cantholysis to prevent the compartment syndrome and compressive optic neuropathy and damage to the optic nerve. Other type of trauma is trauma to the eyeball itself or trauma to the globe. The trauma to the eyeball or to the globe may be a blunt trauma, closed injury, or maybe penetrating trauma by sharp object, which mean open injury. A blunt trauma or closed injury is an anterior-posterior compression of the eyeball, result in a transient but severe increase in the intraocular pressure, and commonly result in long-term effect, so need good follow-up for good prognosis. Its signs may include corneal abrasion and corneal edema, high FEMA, traumatic mydriasis or iridodialysis, cataract and or lens subluxation, vitreous hemorrhage and or commercial retini, choroidal rupture and or retinal breaks, traumatic optic neuropathy and or optic nerve avulsion. Sometimes there is an occult rupture globe due to the blunt trauma, which means open posterior eyeball injury due to the blunt trauma. The signs of this occult rupture are severe drop in the visual acuity, asymmetry of the anterior chamber depth, low intraocular pressure, poor pupillary reaction, and defective ocular motility. This picture shows iridodialysis. Here the iris is avulsed from its root. The second picture shows high FEMA. Here is a level of blood in the anterior chamber, which means high FEMA. Other type of trauma to the globe or to the eyeball is an open injury by sharp object like knives and which cause well-defined wound that required suturing by 10-0 nylon suturing to the cornea. If trauma to the sclera, use 8-0 Vigil for suturing. The risk factor for traumatic endophthalmitis are delayed in the primary wound repair, rupture of the lens capsule, or dirty wound. All these three factors are risk for development of traumatic endophthalmitis. Other type of trauma is superficial corneal foreign body, which may require, like this picture, superficial corneal foreign body, which may require removal under slit lamp using. Other type of trauma also intraocular foreign body. There is a superficial foreign body and sometimes there is intraocular foreign body, which may require pars plana vitrectomy. The risk factor of intraocular foreign body inside the eye may introduce infection and cause endophthalmitis, mechanical trauma of the foreign body and causing retinal breaks, dissociation and deposition of the foreign body inside the eye and may result in sclerosis bulbi. This picture showing iris prolapse due to penetrating ocular trauma, maybe by knife, which require suturing. Chemical injury to the eye. The majority are accidental, either at work or at home, and a few due to assault. Maybe due to the alkaline burn or acidic burn. Alkaline burn more common and more severe. Example of alkaline burn like ammonia or sodium hydroxide. acidic burn, less common and less severe. Example, after car battery explosions. Both of these chemical injury can cause corneal damage and limbal ischemia. This picture shows the cornea are totally opaque and damaged, and there is a limbal ischemia. Emergency treatment for patient with chemical injury by copious irrigation and removal of any foreign particle, then usage of topical prophylactic antibiotics and cycloplegia with close follow-up. Main management line or rules for all patients of ocular trauma are: first, we should exclude other life-threatening injuries, documentation of the visual acuity, administration of empirical prophylactic systemic antibiotics, check tetanus immunization status, careful and thorough examination of the injured eye, wound cleaning and eye closure until the time of surgical interference, avoid MRI examination for suspected ferrous intraocular foraminopathy, can use X-ray or CT scan. Lastly, close follow-up. In all our lectures, our reference is Kansky textbook, 7th edition, 8th edition, and the 9th edition. شكرا جزيلا.